Hi, everyone. Thanks for coming today. And the first thing I want to say is I'm really delighted to be here with such an esteemed panel of colleagues, but also I really feel blessed to call all of these people my friends. And so it's fun to be having a conversation and with all of you about this really important issue that's going on in society right now. And I also want to congratulate Ken Warner on his official retirement. Is this maybe one of the last things you're doing? Yeah, as of May 31st, Ken will be officially retired. So hard to think about. And also, Professor Jacobson has an impending retirement and just gave his last lecture in a class today. So congratulations to Peter. All right, so there are actually a number of provisions in the Affordable Care Act that are important for public health. And when I say that, I'm thinking about provisions that focus on either primary or secondary prevention, or they're provisions that attempt to bring resources aimed at interventions that would influence communities, groups of people, populations, not individual services like medical care. So there's 10 titles or subdivisions within the Affordable Care Act, and as Rich alluded to, we really primarily in all the discussion and debate are focusing on the health insurance industry reforms and other things that are part of Title I. But Title IV of the Affordable Care Act is called the Prevention of Chronic Disease and the Improvement of Public Health. So I just want to, and there's a lot of things in there, but I just want to note what I think are sort of the four biggest provisions in that. And all of them, I would say, are at risk in any ACA repeal, repair, replace, rename, or what I've more often come to feel is revenge, politics and policy in terms of debates that are going on right now. So the first one is the provision within Title IV that does provide first dollar coverage for clinical preventive services, and Rich already mentioned that. I just want to add a little more background to that. This provision in the ACA, I will say, is without question something that evolved from innovative ideas and discussion and research that happened here at the University of Michigan. This idea of value-based insurance reform, I mean, it might not sound like something really out of the box to you, but in the past, in insurance plans, there were co-pays for lots of sorts of things. And the idea was, why are we having people, because co-pays sort of disincentivize people from getting services, right? So what if, again, big, amazing idea, but what if you didn't have people pay co-pays for the things you really wanted them to get, especially if they had preventive sort of benefits, like insurance, like cancer screening for early detection and earlier treatment? So this idea of like, well, what if we design insurance benefits to be more about value than across the board disincentivizing patients from using medical care? What about that idea? So that grew into the Value-Based Insurance Design Research Center that was here at the University of Michigan. So through the Affordable Care Act, evidence-based clinical preventive services are required not only to be covered by insurance plans, but also have first dollar coverage. And that means patients don't have co-pays and they can't apply to their deductibles. I don't know what other panelists think. That may or may not stay in any reforms. What I worry about is that, so what gets labeled as an evidence-based clinical preventive service comes through many different sort of paths, and there's a whole set of services related to women that are now covered, including contraception, FDA-approved contraception, and I'm worried in the future if that's going to hold the coverage for contraception, and then some other services. So I don't think that'll go away across the board, but I think there'll be some debates about what should have that first dollar coverage and what shouldn't. Second, the Affordable Care Act created the National Prevention Strategy, which I will say, sadly, is the first ever national strategic plan that the United States of America has ever had related to prevention and public health. First time created through the Affordable Care Act. The National Prevention Strategy mandated the creation of a National Prevention, Health Promotion, and Public Health Council, which in turn created this National Prevention Plan that has 4 strategic directions and 7 priorities, and in Q&A, if we want to get into that more, we can. This still exists, the prevention strategy in the council still exists, and it's under the Office of the Surgeon General, but as you all know, it's going to need leadership dedicated leadership. It's going to need resources, and it's going to need staff to do the work, and that's really not certain. It's been languishing. These efforts have been languishing. Third, as Rich mentioned, the Affordable Care Act created the Prevention and Public Health Fund, which originally was proposed to have $14.5 billion dedicated to a number of different public health initiatives over a 10-year period. In the legislation, it says that this is going to also be the first dedicated federal funding for prevention with the purpose of, quote, to provide the expanded and sustained national investments in prevention and public health programs to improve health and help restrain the growth in private and public health care costs. Fund, you saw on the slides, has been used for a lot of basic public health, standard public health stuff that we do, but also some new and innovative interventions, community-based ones, where community members were helping to identify problems, identify the solutions tailored to their communities through the community transformation grants. The REACH, Racial and Ethnic Approaches to Community Health Program, was funded through this. Since 2013, the budget allocations that should have been going to this have been less than expected, and part of that was because of cuts through mandatory sequestration, but also in part because of politics. And in the American Health Care Act, the proposal for this fund was to just decimate it, right? There's $0 proposed, and actually if you look at that proposal right after, it says that fund's gonna be, no more money's gonna come into it, and in fact, all unspent funds dedicated to date would be pulled back. And then right after that, it says there'll be $422 million more dollars for community health center. $14.5 billion, $422 million for community health centers. I was recently talking to a friend of mine. I used to be on the board of a community health center in Washington, D.C., and I was recently talking to the executive director of Whitman Walker Health in D.C. So, well, what do you think about that $422 million additional dollars for your mission? And he said it's almost exactly the same amount of money that's being cut from Planned Parenthood. So he said the community health center movement in the country really looks at that as sort of like blood funding. They don't want it because it's not, and it's not very much money either. All right, so fourth, and the last thing I want to briefly mention is that the Affordable Care Act brought some changes to the community benefit regulations for nonprofit hospitals. So way back in 1969 was the first time the IRS actually articulated that for nonprofit hospitals to have their nonprofit status, and you know that means they don't pay taxes, right? So from the IRS point of view, what do you have to do to not pay your taxes? You have to provide some community benefit, but that wasn't defined all that well. In 2009, the IRS made some changes to the annual tax reporting that nonprofit hospitals have to do that signal to hospitals that community benefit is not just charity care and writing off bad debt, buying really big expensive MRI machines that members of the community will use, things like that. I mean, they really had to do a better job of defining what was providing benefit to the broader community. And in 2010, the Affordable Care Act expanded and clarified those community benefit requirements for nonprofit hospitals, and it included a couple of important things from a public health perspective. First, individual hospital community benefit activities, the law says, should be based on knowledge regarding the actual needs of the community. Go figure. And to get to that, hospitals need to conduct community health needs assessments, CHNAs or Chinas, every 3 years, and that conducting these community health needs assessments, they actually had to be conducted by people who had some knowledge of the community and public health, like graduates with MPH degrees from great schools of public health, like the University of Michigan, things like that. So this requirement in the Affordable Care Act has been viewed by a lot of people as this is actually going to be a great resource to get hospital dollars invested in more upstream determinants of health. We still don't know sort of what's going on, how much has the needle moved with this whole process. But again, there's some potential here. However, it doesn't really appear that the Trump administration might be having the IRS enforce, carry out, I'm good, I'm done. That part of the law to the letter, so. few things about public health and the Affordable Care Act. Thank you.